Hello, everyone, and welcome to this virtual stage. Just going to give it a couple of minutes for people to join.
Thank you so much. Good morning, good afternoon.
Good morning and good afternoon.
I'll throw in good evening for good measure. And Happy New Year.
Happy New Year to everyone.
Good evening. It's 7 p.m. in Uganda.
Wow.
Evening already. Uganda's always ahead of everyone. Leader.
Right, maybe a bit dark, but let me try and get some light. Is that any better? Okay.
Great. Right, well, we've given it a minute and I think we've got an excellent quorum and I think people will keep joining. So thank you all for joining us today, our first virtual stage of the year, and a very happy new year to all of you. I know that wherever we are in the world, COVID-19 and the ongoing rolling nature of this pandemic is causing a lot of challenges. And we wrote a piece, myself and the co-founders will put it in the chat, where we said we feel like this is not really a crisis, a health crisis, but it's a crisis of political will and leadership. And we know what we have to do. We just darn well need to do it. And we're hoping to hear from 5 esteemed people in the next hour with a conversational approach where we'll have a Q&A session moderated by me. And then we'll open it up to Q&A from the floor. So given that we've got 5 brilliant speakers and just an hour, I'm going to dive straight in and introduce our speakers. So we've got Dr. Abdi Mahamud, WHO's Global Incident Manager of the COVID-19 Incident Management System team. So welcome to you. We've got Dr. Ali Moghdad, Chief Strategy Officer of Population Health and Professor of Health Metric Science at the Institute for Health Metrics and Evaluation, and that's at the University of Washington. We've got Tracy Kubakindo at 7 p.m. in Uganda, a Regional Director, Last Mile Health in Uganda. And we've got Dr. Bonaventure Ahaisibwe, Regional Director, Strategy Innovation, Sea Global Health in Uganda, and Dr. Fumie Griego, Deputy Director General and Chief Operating Officer of the IFPMA. So thank you to all of you for joining us today. We're really looking forward to hearing your thoughts in the next hour. So I'm going to kick off with an opening round of questions to you all. And if I can kick off with Dr. Abdi Mahamud, can I see you on the screen? I'm just looking at my... Dr. Abdi, while many went on holiday in late December, the WHO was working to better understand and provide up-to-date guidance on the Omicron variant. What do you think Omicron has taught us about what it will take to end the crisis phase of the pandemic this year? And if you could speak for up to 5 minutes, that would be great so we can get through to everyone. Thank you so much.
Hello, everyone, and Happy New Year. Thank you so much for inviting me to speak on behalf of WHO and the work they have been doing since designation of Omicron as a variant of concern 7 weeks ago. As we start the new year and enter the 3rd year of the COVID pandemic, it's important to reflect on the last 2 years and what we need to remind how interconnected we are. Then Omicron has definitely brought that message home. Globally, as of today, we have 306 million confirmed cases and over 5.5 million deaths reported to WHO. So as a WHO, immediately after the designation, we activated a dedicated incident management team that I'm leading, and convened thousands of experts around the world to share and discuss the latest data in real time. The overall threat posed by Omicron and other variants largely depend on 4 key parameters: how transmissible the variant is, how well the vaccines against the disease and death, how virulent it is, and understanding of the population dynamic and adherence to countermeasures. What we know thus far on Omicron is that present in nearly all countries around the world and rapidly replacing Delta. It has an astronomical growth advantage potentially driven by immune evasion, although initial reports pointed towards a relative lower severity compared to Delta. The tsunami of Omicron cases seems to be taking a different trajectory in countries where it's overwhelming and already an overstretched health system. On the brighter side, preliminary studies show that the current vaccine developed against the ancestral variant are still effective in protecting against severe disease and death. Omicron, more than any other variant, has shown that one measure on its own is not enough, but rather needed to be targeted and context-specific to the local drivers of transmission, with the main objective of protecting the vulnerable. Measures now need to be carefully balanced: public health, economic, and the societal implication. Vaccines, even with boosters, are not enough if we are not getting vaccines to the unvaccinated, particularly the vulnerables and the high risk in each country. Target testing is not enough if not linked to public health measures. Mask wearing is not enough if indoor spaces remain crowded and poorly ventilated. Travel restrictions are counterproductive in a highly transmissible variant because push other countries not to share information on timing. So if we want to end the acute crisis phase of this year, we must follow the principles behind the science in understanding the virus, find a solution to find it, and build on solidarity in sharing and delivering tools widely and wisely. The enough doses of vaccines globally, if shared equitably to achieve the target of 70, as outlined by Dr. Tedros in his New Year resolution. The vaccine inequity between countries extend within countries, driven by vaccine hesitance and complex interaction of social democratic factors. We urgently need to address both the supply and the demand side of vaccine equation to rapidly increase vaccine coverage through community engagement and communication by trusted local leaders. While a healthy skepticism is the foundation of scientific thinking, we really need to fight the lies, misinformation, and disinformation often spread by a small group with vested interest. The COVID pandemic has been described as a tsunami in which young and healthy with a robust immune system are able to outrun the wave to higher grounds, while the elderly and the vulnerable with weak immune systems struggle to reach safety before being swept to hospitals, to ICUs, and sadly to some 5 million to mortuaries. We could either build a temporary seawalls preventing virus introduction and spread, or build an immunity wall to manage Omicron and prevent emergence of other. No country can tackle this alone, and no part of society can be disregarded. The virus will continue to evolve. That's part of nature, and the threat of our health system and our way of nature remain endangered, but we remain optimistic this year. That can be the year we end the acute phase. I leave you with a quote from the late Archbishop Desmond, whom we lost recently. Hope is being able to see that there's light despite all the darkness as we enter the third year of this pandemic.
Thank you, Dr. Abdi. Really lovely to finish on that quote and remember the Archbishop, and that we all need to keep the hope. It's been a long 2 years already, but we definitely need to muster the courage and strength for the next one. I'm going to turn now to Dr. Ali Moghdad. So, Dr. Ali, thank you so much for being with us today. The IHME has been a leader in tracking and forecasting the trajectory of this dynamic crisis. What's the data telling us as we look towards year 3 of this pandemic? And what's most critical, in your view, to ending the crisis phase of COVID-19?
Good morning from Seattle. And thank you for having me. And I'm complimenting what Dr. Mahamud has said already. According to our projections, Omicron is likely to have spread to nearly every country in the world by now. And we expect that every country will have this wave of Omicron by the month of January. In our analysis, we see a high level of infections reaching about 80 million by mid-January globally, 80 million infections. We expect 50% of the world will be infected in the next 8 weeks from Omicron. Data from South Africa, the UK, and the US, a lot of data from the US right now is showing that Omicron is substantially less severe than Delta. And there is a high fraction of asymptomatic, about 80 to 90%, especially if you're vaccinated or previously have been infected, you're most likely to be asymptomatic. So hospitalization is down by about 50%, and mortality is reduced by about 80 to 90%. Again, this is comparing to Delta. It doesn't mean it's much better, and still this virus is deadly and sending a lot of people to the hospital. Putting all of these together, we're expecting about 8 million cases by late January to be reported globally. Given that so much infections are occurring right now, many hospitals will be overwhelmed simply because of the patients that are coming to the hospital will be detected having COVID-19. They're not coming for, they're coming with COVID-19 simply because of the high rates of infections. Add to it, the high rates of infections are impacting the medical staff as well. So you have a lot of physicians, nurses, and medical staff are not able to come to work because they are infected and they need to isolate and stay at home. So we'll see a lot of pressure on hospitals in the coming couple of months here globally and in the United States. And that will add a lot to the burden on hospitals that are already exhausted simply because they've been going through this for the last 2 years. For individuals that have a high risk for bad outcomes, people who are immunocompromised, people who have high risk factors, and especially people who have not been vaccinated. And I know Dr. Mahamud talked about reaching out and decreasing hesitancy out there and getting people to get their vaccine and their booster if they have access to it. Again, keeping in mind there is a lot of inequality in vaccine distributions, and rich countries could do much better in order to make sure other countries have access to the vaccine. But for those people, the strategy to reduce the risk remain exactly the same: vaccination, getting the third dose when appropriate, and of course, high quality masks, which are not easy to find these days and they're expensive, even when having shortage of KN95 or N95 in our hospitals right now, and we are very careful about how we use them. And of course, avoid crowded indoor settings. I'm very much concerned, as Dr. Mahamud mentioned, that we could have another variant, an escape variant that will make the vaccines less effective. We're going to have globally, unfortunately, a tough January and February for many countries where hospitals will be overwhelmed, a lot of infections, and we need to do our part to keep our hospitals running, basically help the hospitals so they can help us. Over.
Thank you so much for that, Dr. Mokdad. We'll come back to you in the course of the conversation and the Q&A. I'm going to move now to Dr. Bonaventure Ahaisibwe, who works at the community level and health systems level in Uganda, but also regionally. As you look at the year ahead, what are your top 3 priorities for African health systems to end this crisis this year? Over to you.
Thank you so much. Kindly confirm you can hear me loud and clear.
Loud and clear.
Yeah, thank you. So I think some of the key lessons that we've learned as looking at a number of African countries and the effect of COVID-19 is that if I were to use the African proverb, you cannot fatten the cow on the market day. You cannot create the needed redundancies and fix the inefficiencies in the system in the face of the epidemic. And I think another thing that we've always known, but which has sort of like really been underlined by the COVID epidemic, is that in many ways, some of the international responses that are supposed to trigger concerted international response in the face of the pandemic, unfortunately have had the reverse impact of deepening stigmatization and alienation of Africa. For instance, declaration of variants of concern. We've seen panic responses which have further alienated Africa. So leveraging resources that are available and easily accessible to respond to those known disparities. For instance, we've learned that human resources for health presents potentially the most fungible resource within the health sector in Africa. And it's critical to keep it up and running in an epidemic, and also more so to have it well prepared to face challenges like this epidemic. And I think the other key piece that we take away from this as African governments is that we cannot always look out for support from the global north to end epidemics. We have to invest in the health sector. There's room for support, there are fragile systems, but there's a need for deeper investment in the health sector, both to protect us from such epidemics, but also the health sector as a driver for the broader economy that keeps us insulated from such shocks. And I think finally, I think the other key piece that we take away from this is that it has to be all hands on deck. We can't just look to the health sector, to ministries of health to fight this. We have to leverage a broader national infrastructure, all of government platforms for coordination. The private sector and the third sector have to come in to absorb some of the exponential pressure that meets the health sector in moments like this. Thank you.
Thanks so much. That all hands on deck approach, and your point about needing to go way beyond the health sector is absolutely taken on, and something that we heartily agree with. Thanks so much. I'm going to turn now to Tracy Kubakindo. Tracy, you're both a nurse and a public health leader in Uganda. As we look to ending the crisis phase of this pandemic this year, what do frontline health workers like yourself need most? Over to you, and thanks for being with us.
Thanks, Alois. Thanks for hosting us for this important discussion. It's great to be with all of you here today. In my current work at Last Mile Health in Uganda, we talk a lot about the 5S. So this stands for salaries, it stands for supervision, supplies, and that health workers, frontline health workers, need to be integrated into the health system. So today I want to talk about two of these 5 S's in particular: skills and salaries. I think we can agree today here on this forum that health workers are burning out at a faster rate than we can replace them, and they're not being paid enough. We need reinforcements, and we need them fast, meaning the world needs to train more health workers to cover a pre-existing shortage of 18 million predicted for 2030, and to also replace those who we sadly lost in the last 2-3 years. And to ensure, so this will help us to have enough frontline health workers delivering services that are related to COVID-19, like vaccination, because as Dr. Raj likes to say, vaccines are not going to administer themselves. So health workers need to be there to administer them. And a thought that I had when I was thinking about this question is, if only countries would commit to, it's great to have vaccines, but if only we would commit to say, for every, say, 1 million vaccines that we're going to manufacture, we're going to make sure we have, say, maybe 10 health workers trained, or we are training 10 health workers at the same time to be able to administer those vaccines. And so on top of that, we would also need more health workers to ensure that there is continued access to essential health services, so that gains made in tuberculosis treatment, in HIV treatment, malaria, routine immunizations for under 5s are not lost at this time, because we are stretching the health workforce to fight the pandemic, but then also the same health workforce is supposed to continue delivering essential health services, but then we are paying them less. During the pandemic, I've seen our health workers' roles and responsibilities expand enormously, but this has not been reflected on their paycheck. So 2 things: skills in COVID-19 treatment and COVID-19 surveillance and COVID-19 vaccination, but then also skills in other things that we have not been thinking about as we have all been, our minds have all been wrapped around the pandemic. And that's why we have seen cases, for example, in Uganda, malaria increase over the last 2 years, and patients who have been accessing, patients who have had chronic illnesses staying at home and not getting treatment. And so there's been an increase in comorbidities and also in NCDs during this time. So if I could talk a little bit about remuneration. We have had strikes. I think we have all seen strikes all over the world during this time in the last 2 years. In Africa alone, there were strikes by doctors, nurses, medical interns, lab technicians, striking against poor pay and poor working conditions in South Africa, in Kenya, in Nigeria, in Uganda. We recently finished that strike. But the sad thing is that this is not being taken as a serious issue. It should be obvious that if the workload has increased, then the pay has to increase. So I think in order to keep the health workers motivated and working at this time, we really need to show that we recognize them and we appreciate the work that they're putting in fighting the pandemic, but also continuing essential health services by improving the remuneration that we're giving them. So just to wrap up, to protect the health and well-being of all cadres of health workers, we need to make sure they're being adequately paid. I can't stress that enough. And the question for us as an international community of advocates, of funders and implementers is how can we make this happen? Beyond discussion, beyond roundtables and beyond conferences, how can we actually make sure that health workers all around the world are being adequately paid for the work that we have been putting on them now and also before the pandemic?
Thank you so much, Tracy. Really powerful. And the 5 S's, really good focus points for us as we think about how to support healthcare workers, and the skills and the salaries being perhaps the most important of that group. If you have any more materials on that, please do share in the chat. It'd be great to see. Thanks so much for that from the ground inputs in terms of the healthcare workers' view. A different perspective now. We're going to go to Dr. Fumie Griego from the IFPMA. And while 2021 was the year of the vaccine, welcome, Dr. Griego. 2021 was definitely the year of the vaccine. It was also a year of stark vaccine inequity, which is prolonging this crisis. From your role and your vantage point at the IFPMA, what key actions must define 2022 to end the crisis? And what role is the IFPMA playing to do that? Over to you.
Great, thank you so much. Can you hear me okay? Great, and thank you so much for the opportunity to speak to this group on this important topic. Indeed, 2021 was in some ways a miraculous year of vaccines. I think it is important a little bit to step back and think about where we started a year ago. We went from 0 to 11 billion doses. It's an unprecedented scale of manufacturers, both from developed and developing countries, coming together. It's been my privilege as part of IFPMA to participate in collaborations like COVAX in order to be part of the biggest immunization campaign in human history. So I think there's a lot, as you mentioned, that needs to be done better and needs to improve. But I think it's important to step back and think about what we've already achieved in the short period of time, but at the same time, all that has left to do. And I would echo a number of things that other panelists have already mentioned. I think what this virus has done is very insidiously prey on the vulnerabilities and weaknesses in the entire healthcare infrastructure. And so what really this underscores is the need for UHC investment. I think we've turned a bit of a corner over the last even few weeks in terms of the number of doses that are being redistributed more equally to developing countries. But the biggest hurdle now is country readiness and systems readiness, and the kind of investment that other speakers have already spoken to. And Eloise, you mentioned, very much early on about political prioritization and some of the work that needs to be done altogether in terms of a number of sort of, long existing problems in terms of reaching UHC in many countries, funding sufficient sort of infrastructure to deliver vaccines safely. And this means particularly scaling up cold chain and other new requirements that mRNA vaccines, which are different in terms of some of the supply needs compared to existing technologies for vaccines. And also an unprecedented number of health workforce that's needed in order to service an adult population that we're not used to servicing. So again, we've collaborated with Gavi on a number of childhood and adolescent campaigns, but it is a different matter when we're talking about immunizing the entire adult population. So I think there's a lot left to do in 2022 in terms of also sort of regulatory infrastructure at country level to facilitate the deployment of vaccines. And as other speakers have mentioned, vaccine hesitancy has been an important factor in uptake, not only in developing countries, but also in developed countries as well. So, and I think, what seems to be the case for Omicron is that we don't necessarily need a new formulation in terms of vaccines, but I think that's also something that we're quite watchful of as the virus unfolds. And different variants may be coming in the future, is that there may need to be continued need for innovation, scaling up of new types of vaccines if necessary, and ensuring that we have a more equitable access using platforms like COVAX, but also other mechanisms as well to help facilitate countries being more self-reliant, as one speaker mentioned, in terms of supplying and distributing their population. So I'll stop there and just really echo what other speakers have said about the importance of an all hands on deck approach and really using our collective efforts to reinforce the need for investment in infrastructure and really the vulnerabilities and gaps in universal health coverage that we've seen. And unfortunately, we're also seeing this in even developed countries. And so I think it's a real opportunity for us to really look at the UHC and infrastructure needs, not only to address this pandemic, but future pandemics and for routine immunization and other health issues.
Thanks very much, Dr. Griego. So just going to have a few minutes of discussion between the panelists. And while I've got you, Dr. Griego, just thinking about what you said, I think one of the big kind of challenges for 2021 was this 11 billion doses figure, which gives such hope and such excitement that we're on our way to vaccinating the world. And yet 40% of people haven't had a dose, and latest Our World in Data saying over 90% of people in low-income countries not having a dose. So are there things that would, from the IFPMA perspective, are there things that you would need, like that would help you be able to deliver vaccines more equitably? Are there things that you're asking for? Or what measures are you taking in and of yourselves without asking permission, if you like, from governments to get to that equity, elusive equity that's been so hard to achieve? Over.
You know, these are really important questions, and I think there have been a lot of efforts to try to encourage dose sharing. I think we all know from what's happened over the last year that a lot of the more affluent countries were able to secure contracts sooner. And understandably, and this is where I think we have to all remember, we didn't know which vaccines were going to be successful. There were a number of candidates who never made it to market because they were not as successful as other candidates. And so based on the contracts that other countries have secured, they were reluctant to release that because they were very interested in making sure that their own populations were covered. So I think what we've been encouraging over time is as countries realize that they have excess supply, to facilitate the transfer of those through donations and other mechanisms. COVAX has been an important part of that, but also through bilateral exchanges. So it's something that IFPMA has been working with both governments and companies to try to facilitate. And so I think that is a lesson learned that we need to all reflect on to see how we can improve that process for the next pandemic. But for this one, I think we're trying to sort of help facilitate those discussions to get those dose sharing sooner rather than later.
Thank you, Dr. Griego. A question maybe for Dr. Mahamud and Dr. Mokdad from slightly different perspectives. I was struck, Dr. Mahamud, about the point you made, the very salient point about travel restrictions being counterproductive because it represses countries from sharing the science. And with what we heard from Dr. Mokdad about the spread of Omicron and how much of the world will be infected in the next 8 weeks, I've also always been struck that we've struggled collectively, as I think as a community working on these issues, to kind of give global advice, if you like, about what countries should and shouldn't be doing, the sort of what is the best practice. I sit in Europe, and even in the European Union, there are sort of different approaches, one country to the next. Does the spread of Omicron sort of being everywhere pretty soon give us the opportunity to actually push for more united approaches with policies that should be taken by governments and by regional levels? And what would the most important of those be in your views? Dr. Mahamud and then Dr. Mokdad.
Thanks. I think if you have been following WHO and Director General Dr. Tedros from day one, or been calling our message remain the same sometimes, unfortunately, it hasn't been taken that serious. Again and again, it's the science-driven policy and solidarity. We are in this together. Omicron has shown again for 7 weeks, it's almost every part of this world, even in Antarctica. We live literally and figuratively in a small global village. So what we do as a global community will have an effect. So I can understand some member states saying, me first. But in reality, if you have a certain large part of the world that you allow the virus to go in natural infection, because it's the experiment. So we are letting experiment run. And then the variant will come. So it's in the interest of the rich world to make sure that you help the poor country. It's just like the global war on terror. I'm not bringing politics to public health, but just that understanding that the world is safer when the global security focus on those countries, part of the world. So almost $8 trillion have been spent for the last 20 years as per the analysis from university, where almost building borders have been done. That level of understanding that health security is a national security. The investment to protect your population will require support to the other weaker part, not only from an ethical perspective, not from an economical perspective, but from a self-security perspective. Is the interest of everyone to have that solidarity. On the second part, the science is very clear. Unfortunately, I think we'll say that Robert James, when we mix science and politics, always politics end up. So to be a scientifically driven data decision making is going to help everybody. The point on the travel restriction, I think if you have been following what's been saying, it has to be risk-based and timely. When this virus appeared, some countries did that. But 2 years into this, where we know SARS-CoV-2, that it is going to evolve the variant, it's easier building an immunity wall rather than building walls around in your country. If you're an island, you will be able to do, but a big country, it's very unfortunate. We live in a world interconnected. So our message really remains the same throughout the period. It is follow the science, whatever it tells us. Be flexible. Of course, for the public, it's very hard when you see the sausage making of science in the public in front of social media and media. What used to happen in conference now is happen real time in Twitter and media. But follow the science there. And then that solidarity, it's in our ethical, economical, and all aspects of society that we have to come. No one is safe unless every one of us is safe.
Well said, thank you. And just before you answer, Dr. Mokdad, I wanted to bring your attention to another question that's relevant and related in the chat with our collective, from Jenny Ottenhoff of the One Campaign. Our collective objective is to vaccinate the world, but the definition of what that means is changing by the day. How do we better account for the changing nature of the virus and science in our advocacy for vaccine access? And are there some underlying assumptions that we should be challenging? So sorry to throw that at you when I launch another question, but if you could integrate that, that would be fantastic. Over to you.
Thank you. Let me address a little bit about the travel ban. Let's look at the facts. In the United States, we had the first case here in Seattle, and it was treated in our hospitals. It was spreading in Seattle, in our nursing homes, and we had a ban for travel from China. And you look at what happened in New York. Cases started appearing in New York with the travel ban, and they came from Italy. I mean, we were able later on to find out they came from Italy. We had a ban of travel on China, and it's already spreading all over the world. So it came to us from Italy. It didn't work. And then when we had the Omicron in South Africa, many countries automatically put a ban on travel from African countries. We did it here in the United States, and it was announced, and it wasn't done immediately. It was like, we will start the travel ban from African countries on Monday. And it's like 3 days later. So here is a contradiction. I mean, these are facts, and these are the contradiction of policy and politics regarding science. If you want to shut down, you have to have a total shutdown from every country in the world. Yes, you could be an island like New Zealand, and you say, I don't want anybody to come to New Zealand from air, from sea. It's possible. Otherwise, it's really, you're picking and choosing, and eventually you're punishing the good people in South Africa who told us what's happening, and they needed the airlines to keep coming to give them supplies. So it doesn't work, and it has to be done. It has to be done in a fair way. As far as of the vaccines, yes, we are changing the definition of what is vaccination. We're realizing right now with COVID-19 that it's a 3 doses regimen, not 2 like any other vaccine we give. In the US, we give 2 measles, we give 3 DTP. So many vaccines are giving more than 1 dose, more than 2 doses sometimes. So yes, we're realizing it's 3 doses. We don't have enough vaccines, and we need to make sure that we have to vaccinate the world. And I totally agree with all my colleagues saying we're not safe here in the US or anywhere in Europe, anywhere in any rich country until the world is safe and until everybody else is vaccinated. But we have a shortage of vaccines, and we haven't done a good job of scaling up production, helping countries to produce and distribute and vaccinate, as my colleague said, health professionals to deliver the vaccines. But also we should invest in the infrastructure to make vaccines in many countries in the world. So if this happens again, and we can use it for other diseases and for other vaccination. Over.
Thank you very much. And a related question from my colleague Carolyn touches on the point you made about this becoming a 3-dose regimen. So far, obviously, Israel's on round 4, and we know that other countries might follow suit depending on what comes next. And of course, then there's the new wave of potential variant vaccines that might change the goalposts again. There's a question in the chat for Dr. Griego. What are the types of regulatory policies or changes that could help countries access pandemic vaccines more quickly or more easily?
So just quickly, there are a number of things that under traditional, even in more developed countries, stringent regulatory requirements that I think we've seen a lot of countries show flexibility that has facilitated faster national approval. You know, it can range from something that seems rather simple, like labeling in different languages and requirements, and especially for more less resourced regulatory authorities to reference and refer to findings of, you know, WHO guidance or other stringent regulatory authorities. So there are a number of things that I think many countries have done to facilitate that, but unfortunately, not all countries were, you know, ready to approve the vaccines as soon as they were available to be shipped. So I think there's a number of lessons learned on how those regulatory hurdles could be facilitated.
Thank you very much. We've got another great question in the chat point as well, saying great presentations. We can easily divide LMICs into 3 categories: lowest vaccination rate, reasonable vaccination rate, and great vaccination rate. Countries with the lowest rate require different tools and approaches than the other ones. Are these efforts on packaging tools / lessons learned based on the country's situation? Does anyone want to, I'm wondering if Tracy or Bonaventure have answers or thoughts on that question. Are there efforts? Sorry, are there?
I mean, public health
are
is
there efforts? Yeah.
Public health is local. So yes, it's not even a country level. It should be even at the subnational level.
Yeah.
And every policy is totally different when it comes to the context. And quite honestly, you are dealt a deck of cards and you have to play it. And you have to go by region and geographic location and see what's happening, what's driving the hesitancy. Involve the locals to help you to increase vaccination rate. Let them be part of your efforts, but you need to talk to people, and you shouldn't be shaming anybody not taking the vaccine. And of course, it's a supply issue and resources. Right now, many countries, quite honestly, from the West are donating vaccines to countries. But giving me a vaccine arriving to an airport or to a port is not going to help me right now. I need the logistics, I need the manpower, I need the finances to be able to deliver these vaccines. So it has to be at the local level. It has to be also from donors to take into account that there is not only giving a vaccine and it's done. You need to help countries to also provide these vaccines.
If I may add.
Please, and then I'll come to Tracy and then Bonaventure.
Yeah, no, at WHO and UNICEF and President Gavi, we are coming together trying to say how do we push. If we have been following, the supply chain has opened unless countries start going crazy with their booster doses. We are able to do that. So we're coming together, as Dr. Matt said, it's at local level. It's that local leader who's trusted. Not the media, not anyone, is that trust at the local level. So we're pushing very much now that the supply chain pressure is released, how to better engage the community, how to deliver the most vulnerable population. So WHO, UNICEF, Gavi, and all the active principles are now going on a full scale to ensure that the WHO Director General and UNICEF Executive Director appointed Dr. Shabani, a well-renowned public health leader who work in this global. So we will see a very strong push and collaboration with all the partners, but I agree that it's local, it's the local community, the local street, the trusted leader, the religious leader or the GP that will make the difference, bring the demand while we resolve the supply. Thank you.
Thank you. Tracy, did you want to come in?
Yeah, if I may chime in, that's a really great question. And I think this division by lowest vaccination rate, reasonable vaccination rate, and great vaccination rate it applies to countries, but it can apply to districts. We are seeing it applying to sub-counties now. If a sub-county has maybe 365 villages, you will find 5 villages maybe don't want the vaccine. And then the rest of the 300 really want the vaccine. So there's a lot for us to learn. And in Uganda, I think Ministry of Health is really doing a great job on recording some of the reasons as to why there are discrepancies in the attitude towards the COVID-19 vaccine. But mostly we have seen, and Dr. Bonaventure could back me up here, that there is a high demand for vaccines, especially in the rural areas. But as Dr. Ali said, the logistics are still missing. And then also the health workers to administer the vaccines are not enough, especially for areas that are remote, that are hard to reach. The transportation is difficult, and you find there's not enough cold chain containers to go around. So I think it's important for us to keep recording and noting down these challenges, but then also to Dr. Ali's point, it's not enough to push vaccines, especially vaccines that have 28 days to expiry, to low middle income countries and expect us to consume all of them in those 20 days, given the challenges we have with the already low number of health workers and the logistics and then the planning that needs to happen, and then the remedial trainings that need to happen. That we have tried to innovate around having virtual trainings, but then it's not the same as an in-person training. So you find there's not enough time to train, plan, transport the vaccines, and then administer them within that short time frame.
Thank you, Tracy. Bonaventure, over to you.
Yeah, thank you so much for that question around different strategies for different categories of countries. I think absolutely context is different, and it's very important to have different approaches in that regard. These vaccines are not airborne. They have to be delivered through some mechanism. So you have very fragile systems, the ability to deliver those vaccines, especially if you're not able to come up with long to mid-term strategies about vaccination approaches in the context where you're getting vaccine donations coming in an unpredictable fashion. So you do a vaccination campaign, which is sort of like structured to last 3-4 months and drive access. You find, I saw, for example, there are places in Uganda where vaccines were being given at certain bars because bars were thought to be popular places for like the youth or other people. And then you do that for 2 months. And when people are beginning to realize that that is a place where you pick vaccines, then you realize that the vaccines are not available. So that place is no longer a vaccination point. And when you're going there to pick the vaccine, and then at that point, you realize that that place is no longer a vaccination point. So if you don't have like long to mid-term strategies, it becomes difficult to have a consistent flow. I also wanted to make a quick comment on the vaccine sharing, dose sharing arrangements. They sort of like can easily be romanticized, but they actually a very painful arrangement if you come to think about it. In many ways, it's like saying that rich countries should be self-aware and sort of like when they've eaten enough, regurgitate something for the poor to feed on. It's from like a logical standpoint, humanitarian standpoint, is extremely painful. If you think back to when the epidemic had just started, we saw human beings in all walks of life, from resource-rich settings, from resource-poor settings, going into knee-jerk responses, hoarding tissue. It's like human instinct to be selfish. You'd think that 2 years into it, at a national level, we'd have learned lessons and evolved to have some instruments or cross-jurisdictional mechanisms that help protect public goods so that they are available in a rational way. We know that there's a fireman's mantra. If you have air, if you have fuel, and you have heat together, you'll have a fire, and we know that. So if you have vulnerable people, the most vulnerable, the elderly, the frail, and you have the virus spreading, and the most vulnerable are not protected, the virus will stay longer, you generate more loads, and it spreads faster. And the moment that happens, these viruses will speak to their cousins, and you get variants. They get progeny who are more resilient. And this will come back to bite everyone. It comes back to bite the global north. We're in a world where the longest non-stop flight is actually shorter than the incubation period of the COVID vaccine. So you can't use border checking, you can't use these very sort of like myopic measures to restrict spread of the virus. So it's in everyone's best interest. I think we should stop telling rich countries sort of like be humanitarian. This is not charity, it's just logic. that the only way they'll protect their citizens is by protecting the most vulnerable. It's pointless to waste resources protecting those who don't need to be protected. And you think sort of like you're politically appeasing your electorate. Actually, people should challenge and hold their leaders accountable that the only way they will have to protect their citizens is by protecting the most vulnerable where they are. And I think the other key point that we need to be mindful of is in terms of investments in health. We did see, for example, investments in PEPFAR. It was supposed to be an HIV-centric investment, but fortunately in its latter years, it became a lot more progressive and looked at a more comprehensive approach to the health system strengthening. And a lot of those investments have actually been leveraged to protect the world against COVID. It would have been a lot worse if we didn't have such a massive investment in some of the most fragile systems. So I think my biggest point would be that as we're doing investments in health sector, for example, the upcoming USG initiative on health workforce, we should be comprehensive. We can't just plant vaccines. We knew that something big was coming. We didn't know it was COVID, but we knew something was going to come and it was going to overwhelm the siloed, myopic response mechanism we had put in place. It came in COVID, and another thing is going to come. It's not going to be COVID. So if we invest all our energies in the vaccine, we'll sort of be caught pants down, and not too long from now. I'm not trying to pay profit of doom. So we need to be a little more comprehensive in our planning, build strengthened health systems. We need infrastructure for distribution. We need supply systems. We need human resource to deliver these vaccines. Otherwise, loading vaccines in Africa when they cannot be administered, it's total wastage. I think it would be sort of like hypocrisy to the taxpayers from the respective donating countries. Thank you.
Great points, Bonaventure. And I think, not being caught with our pants down next time is really, really important. And I think this is nothing that we don't know. We know that we need health system strengthening. We know that we need a comprehensive approach. And it's almost like the siloization of very good efforts to make advances on particular areas and diseases has sort of captured our attention too much away from the basic kind of ground blocks that we need across the board. Some more questions in the chat. A question to Dr. Abdi about how can we make science, not politics, the face of the vaccine campaign, and would that help to depoliticize some of that, and how do we go about that? Another question for Dr. Griego, who is not with us at present, so I'll save that when she's back. I think she's coming back. And then from Jim Gannon, in addition to vaccine equity, will the spread of more transmissible variants like Omicron and the transition to endemicity make equitable access to therapeutics as well as diagnostics a more important issue than before? And then a couple more questions. You can see there's one building on Tracy's point about delivery challenges being a question of political will. So how can we, those people on this call, those organizations on this call, best help to change that political calculus to get the job done once and for all? So that's three meaty questions I'll put out there. And Dr. Griego, you're back. There's one for you in the chat as well. But I'll let Dr. Abdi and others take on the three I've just read out. Dr. Abdi, over to you again.
Thanks. That's a great question, and kind of the 1 billion or the 1 trillion question. As I said in my initial introduction, resolving the demand side, once we have, of course, the logistic, that becomes more and more challenging. Just before the start of the pandemic, 2019 was one of the most difficult year for measles. After 32 years of no measles in most of the Western country and almost in the America, we haven't had measles. Measles came back to London, to the UK, to US, and even overwhelmed the system in a small island, Fiji. So we have a massive anti-vax movement that are well-resourced, selling lies and lies. 2019 in WHO, we said one of the biggest public health challenges is vaccine hesitance, was number 9. So how we address that, it's a complex social, behavioral element. And I will not say I'm the expert on that, but we really, really require at local level. Some of people vast majority of the people are easy people who are skeptics kind of saying about regulation, spending more time to them and then not dehumanizing or just disregarding them. Having concerns about vaccine doesn't make you a bad person. It's just someone who wants. So I really believe is that local trust and the local person who has influence. We can say anything. We're preaching to the choir. Everyone who is here is a vaccine supporter, but reaching out across the religious, political, faith, sitting down with them and those people and explain why that it's important, not only at them, but also the healthcare workers who have been the last 2 years, every day working in ICU, in wards without taking a break, how we can help them, that society solidarity. There's a lot of good examples. I see it from Pakistan, from Nepal, from Africa, that once you engaged those community, particularly people who are not in the mainstream, who feel like their way of life has been threatened, we can achieve something. It's not a quick fix. It's not a radio advertisement or a fancy advertisement that happens. No, behavioral change does not happen. It requires hard work. Leaders have a role, and political leaders who represent that part of ideology, whether they are in the East or the West, have a significant role. People do listen to their political leaders. And when I say it, whether it's Sub-Saharan Africa, Southeast Asia, in the US, people, they are leaders who have influences, and some of them have coming out. So it's a massive exercise. The community engagement at the local level requires a lot of resources, require a separate plan. I'm glad to hear that Gavi, UNICEF, and WHO are focusing now on the next priority on that. So agreed, there's a lot of reasons why I'm saying that the government may be the face at the national level, but the local level is your local nurse, is your local doctor who's started, who's member of the society. The local religious leaders will have a major influence. So I worked in Nepal and Pakistan and Afghanistan in immunization program, and that building that trust will require a lot of effort. And I believe that the local trusted leaders, we can use that and to gain the confidence, and hopefully we'll have, because not only COVID that's now affected, it's the childhood vaccination, as I said, the gains that we made against measles, mumps, rubella, polio will be lost with the impact of this one. So it's not a quick fix, but it requires an all society approach.
Yeah, great. Thank you. We're closing in on time. So I'm going to ask for 30-second answers to some quite chunky questions. Are we going to need to have more focus on testing and therapeutics? Maybe Dr. Mokdad could take that one. Tracy, there's a point about how can we best support, how could policymakers and influence best support healthcare workers to share what they're seeing in their communities, and Dr. Bonaventure as well. And then there's the question also for Dr. Griego. So if I could go to you, Dr. Mokdad, and then short, sharp answers, Tracy, Bonaventure, and Dr. Griego, go to you for this will be sort of your final answer and thoughts to leave us with.
Yes, on testing, we need to build capacity for testing, but right now, because of shortage of testing and the spread of Omicron, better only to test people who are symptomatic and test people only if there is a decision to be made after the results of the test. If you're going back to work or you have to travel, do a test. If you're staying at home, no need, save it right now. We have a shortage of tests. Yes, on antiviral, we need to invest in it and save lives. They save lives. Even people who are not vaccinated, I mean, we take care of them and we need to provide them with the best medication and make sure they don't die. However, I'm concerned about antiviral. They will suck all the money and resources from other health programs because they're expensive. And we need to make sure, yes, we need to save lives, but at the same time, we need to still build on our efforts to vaccinate and prevent rather than treat. Over.
Thank you so much. Tracy, answer to the question and final thoughts, please.
Thanks. I think one of the good things and the great things that we can do to support frontline health workers to share and advocate for vaccines and great and good working conditions is having them on platforms such as these. I know the Frontline Health Worker Coalition has really done a great job in bringing frontline health workers to speak to policymakers, to write and to share what we are seeing. So that's one way that folks on this call can make sure that our voices are being heard. The other thing is, what's the other question though? I'm just seeing the question. Yeah, so the 5 S's. So I think it's great that now we have the vaccines. Excellent. There's a great production of vaccines and we are getting some donations coming in, but then parting thoughts, we need to think about the other things that make vaccines move and that make vaccines reach people.
Thank you.
So transportation of the vaccines and keeping them in the proper cold chain. And then when they reach where they're going, who is going to administer them?
Great.
So we need to train health workers and we need to pay them for the extra workload that COVID-19 has brought.
Brilliant thought. Dr. Griego, if you want to give a 20-second answer to the question in the chat, and then I'll go to Dr. Ahaisibwe for some final thoughts.
Great. It's a complicated issue, and I apologize. I had a technical malfunction with my laptop, and I'm on the phone now. But I think one thing that that's important to note that for many countries right now, I think what the companies are facing is orders not being placed. Doses are being made available through either bilateral or COVAX or other mechanisms, but the absorptive capacity of the countries aren't there. So whether it's regulatory or for the health infrastructure reasons that other panelists have talked about, even though the doses are being offered, they're not being taken up. So delivery isn't happening even in that sense. So I think what we're really trying to work on with all of the key stakeholders is how do we address the issue of capacity from an infrastructure point of view, the hesitancy and the lack of basically products being ordered, even though we are making them available from the manufacturer side.
Thanks very much. Dr. Ahaisibwe, I'll give you the last word.
Yeah, thank you so much. I really want to, in many ways, ventriloquize Dr. Griego's submission in terms of holistic look at bottlenecks to vaccination. I think we should all achieve vaccination, not just to have vaccines available. If we have everyone vaccinated, and we need to have tailored responses for different countries, otherwise we cannot have a blanket response for everything. Really deeply appreciate the opportunity to join this panel and for all the
Thank you to all of you esteemed speakers. It's been an absolute pleasure to moderate this panel. And it strikes me from everything that's been said is what we think of as a global response to this pandemic has really been a global response to procurement for the pandemic, but we seem to fall off a cliff edge at the next stage. So perhaps that's something we can all work on together collectively and make sure there are no reasons why there are any reasons why we can't have vaccine equity and other COVID tools. Thank you so much, everyone. We'll save the chat and we'll be in touch, and all the best for a brighter 2022. Keep safe. Bye-bye.
Bye-bye.
Bye, thank you.
Bye.